As a reminder, a PDF of these slides, as well as a recording of today's webinar, will be made available on our webpage following today's presentation. We appreciate that you're all busy doing important work, and we're grateful to you for choosing to spend part of your afternoon with us. Here's Dr. Ray.
Hello, everyone. Nice to address you again. So let's get started. So as we always say, our understanding of COVID-19 is evolving rapidly. So the presentation is based on our knowledge as of yesterday at 5 p.m. So anything that is presented here may change, but this is the guidance and information is up to date for now. So I'm Dr. Madhuri Ray, critical care planning lead in the healthcare system support branch of our emergency response. And today we are going to be going over a couple of different topics. We're going to do surveillance updates and clinical updates as usual. And we are going to have a special spotlight on laboratory issues and testing. And then we will have some time at the end for questions and discussion. So here's where we are now. 2 months have passed since the confirmed arrival of COVID-19 in New York City. Over 19,000 people have died due to confirmed or probable deaths from COVID-19 in New York City. There are signs, though, that mitigation measures, including physical distancing, are making a difference. And we are seeing slowdowns, which we'll get to later in the presentation, on a lot of our disease metrics. The number of new daily cases, hospitalizations, and deaths do continue to decline. Some of the alternate care sites are closed. And even though that's true, we must maintain the mitigation measures like the physical distancing until we can safely transition to suppression measures. And I will have a graph on that in a little bit. So for current activities, we do have over 13,000 volunteers registered with the Medical Reserve Corps. These are volunteers in all kinds of sites in the healthcare system: hospitals, nursing homes, mortuaries, and alternate care sites. We are providing hotels used to house healthcare workers, symptomatic people in congregate settings, and individuals discharged from hospitals that are COVID-19 positive and need an isolated setting away from others in their household or residence. There are food distribution programs providing free meals through the New York City Department of Education and the Department for the Aging. And, as we talk about, and we'll get to this in a bit, as we get to we talk about transitioning from a mitigation phase to a suppression phase, we are working to create a stockpile of protective equipment to deal with the evolution of the pandemic in the coming days. So globally, you can see a map here of COVID-19 cases around the world. There are over 3.8 million cases around the world and over 270,000 deaths. In the United States, you can see that our area is still a hotspot in the United States. I think you can't even pick out New York here amongst all of the different bubbles, but there are over 1.2 million cases in the United States. That's about a third of all of the cases in the world. And there are over 75,000 deaths, which is over a quarter of all of the reported global deaths. So in New York City, we have about 175,000 laboratory confirmed cases. There are about 44,000 people hospitalized currently, and there are 19,540 deaths. 14,000 of those deaths are confirmed COVID-19, meaning that there was a positive test associated with that person who passed away, and then 5,378 deaths are probable, meaning that based on their death certificate, it's very likely they died from COVID-19, but they don't necessarily have a positive test. You can see the COVID rates by borough. I think we've showed you this graph on previous webinars, but we have here both the counts by borough and the rates by borough. You can see that the Bronx and Staten Island have the highest rates per 100,000 people in the population, even though Queens, which is right in the middle in terms of the rate per 100,000 people, Queens has the largest number of cases, with Brooklyn and the Bronx coming in behind. And this is the famous graph I have been alluding to throughout the beginning of this presentation. This is a graph from the Vital Strategies COVID-19 playbook. And I'm just going to talk through this for very quickly, because it can help us understand how we think things are going to play out in the near future. So you can see that this first area in light blue, where it says preparedness, that was of course prior to the pandemic. And then containment, many of you may have remembered the initial phase of containment when we were doing a lot of tracking of cases. Mitigation is the phase we're in now. And you can see there is an arrow up, before you get to the top of mitigation, where it says widespread transmission. And widespread transmission, is probably where we still are now, but we are approaching, we've gone over the hump of that curve in the blue mitigation area. And now we are approaching declining transmission, which is in the suppression phase. And what I want you to notice about the suppression phase, where the main activities are testing and tracing, that there are little bumps that come up and down. And that means that, everything is not over once we get to the suppression phase, and that there will be resurgences, but hopefully not to the level they were when we went into the mitigation phase. The other thing that I want to draw your attention to is the arrow at the bottom where it says meet indicators milestones. And it means that, we don't arbitrarily decide to switch from mitigation strategies to suppression strategies. We have indicators or milestones that we measure that help guide us on which phase we should be in. And those indicators and measures are related, very much related, of course, to the burden of cases. And so here you can see the graph of cases, hospitalizations, and deaths. I would encourage you to take a look at our website at nyc.gov/coronavirus and click on the health department link, where you can see an interactive version of these graphs. But as you can see, for cases, hospitalizations, and deaths, they are all declining. Now, this is one of the milestones that I was talking about that help us figure out when to switch from a mitigation to a suppression strategy. And this graph, you can see a line, right, of 200 hospital admissions per day. And as you can see from the blue graph below the line, for the past couple weeks, we have been consistently below that line. And so this is an indication that it might be time to start thinking about new strategies. Here's another milestone, and this milestone is about the burden of people who need critical care in the intensive care unit in our public hospitals, the New York City Health and Hospitals system. And you can see that unlike the total hospitalizations, although the number of people in the ICU is declining, it is not declining as fast, and it is still above the threshold, meaning that this milestone is indicating that it is not yet time to switch strategies. And so you can see that, with more than one milestone, there may be a period where they are indicating different things about our system. And that's why we have not just one milestone. And now for the clinical update. We have a couple slides here on remdesivir. Remdesivir is an antiviral therapy that you may have heard of that was used in Ebola. It ended up not being a final treatment for Ebola, but it does look as if it might have some beneficial effects in COVID-19. And so because of that, the FDA has authorized emergency use of remdesivir to treat hospitalized patients of all ages with severe COVID-19. This is a temporary authorization. Remdesivir is still under investigation. It has not been formally approved. However, in the context of the pandemic, this is the temporary authorization has been granted. So severe suspected or confirmed COVID-19 disease, which is the indication for that remdesivir has been granted temporary authorization for, is defined as an oxygen saturation less than 94% on room air, or requiring supplemental oxygen, or mechanical ventilation requiring extracorporeal membrane oxygenation. Remdesivir is an IV drug. The optimal dosing and how long you should treat with remdesivir is still unknown. There is an emergency use fact sheet provided by the FDA, and these slides will be available for download shortly after the presentation, and we have a link within the slides to that emergency use fact sheet. And we have a little bit of information here about the study that that encouraged the FDA to provide temporary authorization. This is an NIH study that was conducted around the country, and it found patients taking remdesivir recovered faster and had a lower mortality rate based on the preliminary results of this study. This is a randomized, double-blinded, controlled trial. It included over 1,000 hospitalized patients with confirmed COVID-19 who had lung involvement and a need for supplemental oxygen, which speaks to the definition we provided on the last slide of severe COVID-19. And 31% of those patients had a faster recovery. The median time to recovery was 11 days with remdesivir versus 15 days on placebo. Recovery was defined as being well enough for hospital discharge or being able to return to a normal activity level. Mortality was also reduced. Mortality rate was 8% on remdesivir versus 11.6% in the placebo group. A Gilead study found a similar clinical improvement for both a 5-day and 10-day treatment course, which speaks to the duration that remdesivir was provided. These were randomized multi-center clinical trials that included 397 hospitalized patients, not on mechanical ventilation, so that is different from the NIH trial. And the time to clinical improvement for 50% of patients was 10 days in the 5-day group and 11 days in the 10-day group. More than half of patients in both of the treatment groups were discharged from the hospital within 2 weeks. Let me just double check something on the slides. Yep. Okay. So Dr. Schillinger, I am going to give the, I'm going to give the mic to you, and then if you let me know, I can advance your slides.
I think Dr. Schillinger might be having an audio issue, so we're going to advance through her slides for now and hope to come back to her.
All right, well, back to me. So I'm going to talk to you a little bit about coagulopathy and COVID-19, and then we will go back to Dr. Schillinger's slides. So many of you may have heard news stories or heard from, seen patients or heard reports of coagulopathy in COVID-19. And there are several observational case reports from all over the world, Asia, Europe, and the US, and other countries that suggest both a high rate and actually a high severity of thrombotic complications in COVID-19. And we're highlighting one paper by Spezia et al. From Italy, which found that fibrinogen and D-dimer levels were very, very high in COVID-19 patients. And this will be important later when we talk about different approaches to the management of this coagulopathy. Another thing is that, the coagulopathy is very common in the very severe cases, but as you'll see later, we are seeing coagulopathy outside of the ICU as well. And here we have just a series of references, just describing, describing the coagulopathy seen in several series. And as you can see, these are references from around the world. We also highlight, I'm highlighting one here. Number 7 is from New York City, so it is particularly pertinent to our situation. So what is the cause of this coagulopathy, and is this just something that we see in sick people? So, one of the thoughts about the reason behind the coagulopathy is that very sick patients often have coagulopathy, and sepsis, especially when it's associated with lung injury, can predispose to coagulopathy. And of course, we are seeing a viral septic picture with SARS-CoV-2, right, or in COVID-19. Acute respiratory distress syndrome is the pattern of lung injury that, again, we're seeing in severe COVID-19. And so, if the coagulopathy in COVID-19 is just the same coagulopathy that we're seeing with acute respiratory distress syndrome, then it would make sense to follow the guidelines for acute respiratory distress syndrome. And those guidelines say that you should use prophylactic anticoagulation, and that there isn't an actual benefit to using therapeutic anticoagulation. Just as a reminder, prophylactic anticoagulation is a lower dose that you give to patients who have not developed thromboses or clots yet to prevent them from forming clots. And therapeutic anticoagulation is a higher dose, higher intensity anticoagulation to prevent the propagation and promote the dissolution of existing clots. And of course, if you are preventing clotting, especially in therapeutic anticoagulation, there is going to be a higher risk of bleeding complications. And so the question is this coagulopathy seen in COVID-19, is it just normal ARDS or sepsis that we're seeing? Here's just a quick picture. I don't know if any of you remember this image from medical school. I certainly do. But it really shows you how, especially with infectious disease sepsis, especially with lung injury, the clotting or the coagulation cascade here is so intimately tied to injury and infection. And here you'll see all of these, that these cytokines, that the tissue factor exposed in injury are causing the release of clotting factors, which are promoting clotting. Another idea about where this coagulopathy comes from is that it might be just a feature of the virus itself. So we have seen in other coronaviruses, such as SARS or MERS, through both humans and animal models, especially through autopsy studies, that there is an increased propensity to clot in these coronavirus infections. And they're attributing this to, and again, this is another way that an immune response is very tied to clotting, the prothrombotic response, which is about the body's reaction to preventing hemorrhage in the lungs, but actually it can go over the top and create clots. Additionally, there's some evidence that coronaviruses may cause direct liver injury. I think we often associate liver injury with increased bleeding times, but a lot of the clotting factors are produced in the liver, and it could, we're not exactly sure how that would impact the clotting cascade on an individual level. So in terms of the treatment, there's a very widely quoted paper from Tang and colleagues that found a survival benefit for prophylactic anticoagulation. So it's a low dose anticoagulation. It's the kind of anticoagulation that people are often discharged home from when they're in the hospital, using low molecular weight heparin versus no anticoagulation. And this was an observational study. Now, it's interesting because, for hospitalized patients in the US, we would very rarely have patients who are in the hospital for an extended stay who are not on any anticoagulation. But the value of this study is that we do see that it seems like prophylactic anticoagulation is a good idea, which makes sense. And it makes sense because especially when we're seeing ARDS in these patients. What was interesting in their study is that, again, remember I told you about the lab abnormalities a couple slides ago, that they didn't find an overall mortality benefit in their observational study in the number of patients they saw, but they did see an increased benefit based on the severity of the disease. And the way they measured the severity of one of the ways they measured the severity of the disease is through these D-dimer levels. And that's not something that we usually do when we see coagulopathies. An interesting note, and this is from a different paper, but there are theories, and this is again speaking to this idea of both sepsis and features of the virus that might be causing this coagulopathy. Heparin itself has been proposed to have additional benefits in COVID-19 beyond anticoagulation. So there's some, there is some indication that heparin actively binds the S protein of the SARS-CoV-2 virus, creating a direct antiviral effect. Heparin's known to have some anti-inflammatory effects, and there is a thought that endothelial protection, that heparin may provide endothelial protection. And so, we talked about sepsis and all of these inflammatory cytokines that are released when you have tissue injury, and that is the same injury of the blood vessels can also create widespread inflammation. And this is just the results. I just want to highlight that this graph here, this point where it says DD greater than different thresholds, you'll see that it's statistically significant. Heparin, the prophylactic heparin provides statistically significant benefit when we go greater than 6 times the upper limit of normal, but there are non-significant differences for that. I think that, prophylactic anticoagulation is not really a stretch. It fits pretty well into our existing protocols. But the question is prophylactic anticoagulation sufficient? And Helms and colleagues did a multi-institutional prospective cohort study of 150 COVID-19 patients with ARDS. So these are pretty sick patients in the ICU. And they were seeing that while these patients were on prophylactic anticoagulation, they were still developing clots. And I'll speak to that in a minute. They didn't see a lot of bleeding, which was very interesting because in sepsis-related coagulopathies, you often do see bleeding, but they, again, saw this really high D-dimer and fibrinogen in almost all the patients. So Helms and colleagues concluded that this is not necessarily what we're seeing in conventional ARDS patients, and it may be valuable to consider more anticoagulation than standard prophylactic doses. And here I just wanted to illustrate that it's not just the frequency of thrombotic complications, but it's actually the character of those thrombotic complications. So we're seeing pulmonary emboli, but there were strokes. We're seeing pumps and circuitry where these large bore circuits were getting completely clotted off. We're seeing limb ischemia out of nowhere and mesenteric ischemia in this paper. And then, of course, there are other papers that you may have heard of where patients are getting proximal large vessel strokes, cor pulmonale, et cetera. And so these are bad, life-threatening complications. Over here from a different site, we have very quickly, this is a thromboelastograph. And I know that many of you don't see these frequently, but I just want to point out some of the things here that this is showing the very rapid clot formation here. And so you'll see that this is below the range. This is the time it takes for a clot to start forming at the beginning. That's called the R value. And then you can see the amplitude of the clot is very high. And one of the other numbers here is that you see this sort of, this curve just sort of goes on for, this is minutes on the bottom, for 60 minutes and just stops. And that just shows that the natural processes that dissolve a clot after it's formed aren't working in this blood sample from a COVID-19 patient. So again, what does this mean? What labs should be drawn? Should all hospitalized COVID-19 patients be anticoagulated? And that, is that prophylactic? Is that therapeutic? Should we empirically use therapeutic levels of anticoagulation, or maybe, some of what we think of as the big guns of anticoagulation, like tissue plasminogen activator? What should we do for patients when they're discharged? Should we give them prophylactic? Should we give them therapeutic anticoagulation? And so I am raising these questions. I can tell you about some suggestions people have, but we do not know the answer to these yet. So the International Society for Hemostasis and Thrombosis have provided some interim guidelines, which I'm going to look at here. And so you'll notice that they do recommend getting several labs at first, including the D-dimer. And these are not necessarily in COVID positive patients. These are really in a lot of patients because they may develop COVID-19 later, and this can be useful for tracking if they do come back later. And based on those results, they indicate different pathways. There are some boxes here where you actually might consider experimental therapies. Cohoon and colleagues developed some further guidance, and they did this by reviewing anticoagulation protocols for COVID-19 patients in the US and France. They noted that, the institutional guidelines, I think they said, over here we said they are evolving. The paper actually literally said institutional guidelines are lacking. but I thought I'd give him a little more credit in the slide. But these are based on anecdotes and individual experience, not the rigorous publications that we're used to. And so they drew a couple conclusions together, and I encourage you to look at the paper. They have a lot of very specific conclusions. But they noted that most protocol actually advocated for prophylactic to intermediate intensity anticoagulation in all hospitalized patients. Again, many protocols did advocate for extended post-hospital discharge anticoagulation. And I know that even for those of you on the call who are taking care of patients outside of the hospital, this is something you're very interested in. So, you know, again, this doesn't give you a lot of detailed information, but stay tuned and we will update you once that guidance is out. And then I'm going to, should we go back?
We should, yeah.
Okay. All right. Apologies, guys.
I think that Dr. Schillinger should have her audio figured out now. So Dr. Schillinger, if you would just give us a shout, let us know. That would be great.
Can you hear me?
Yes, perfect. Thank you. So we're going to go back and find your slides.
Thanks.
There you go.
Thank you.
Thank you.
Okay. So back in late April, which was not a long time ago, we got the first reports from the UK and some other countries in Europe of a pediatric multisystem inflammatory syndrome. And soon after that, cases were reported, pediatric ID docs were exchanging information about a few cases. The patients were described as having overlapping features of toxic shock syndrome and atypical or incomplete Kawasaki disease. And some, but not all patients were positive for SARS-CoV-2 by PCR. Now, just yesterday, a paper was published in the Lancet describing the 8 cases that were reported initially from the UK. So there's a lot more detail in that paper, and I recommend it. It's, I don't see it cited here, but we can get the citation out to you all. The age range of the patients was 4 to 14 years, and they had persistent fever. Most had abdominal pain, rash, and conjunctivitis. Multiple laboratory markers of inflammation, evidenced inflammation in single and multiple organ systems. And although not all patients were positive by PCR for SARS-CoV-2, all 8 patients had positive serologic tests for SARS-CoV-2. And there was 1 death among the UK patients. Next slide, please. Thank you. So as soon as we heard the report from the UK, we outreached to pediatric ICUs across the city, and in that way identified 15 cases of a similar syndrome that we would characterize as having had some of the features of Kawasaki disease, but not all, as well as a shock-like presentation. The children aged from toddler to adolescent, and all had either subjective or measured fever, and more than half had reports of rash, abdominal pain, vomiting, or diarrhea. Like the UK cases, PCR results for SARS-CoV-2 were positive in only some, 4 of the 15 cases we identified. 10 were negative by PCR, and 1 was indeterminate. More than half of these 15 cases required blood pressure support, and 5 required mechanical ventilation. And none of these 15 cases died. You can see a little bit more detail on these cases and the way we reached out to the ICUs in the health alert, which is cited below. It's important to say that although these cases are clearly temporally related with the COVID pandemic, the relationship between COVID and this syndrome is not yet clear, whether it might be an acute presentation of COVID or a post-infectious inflammatory response to COVID, that needs to be further evaluated and studied. Next slide, please. We have asked providers across the city in our hand to please immediately refer suspected cases to specialists in pediatric infectious disease, rheumatology, and critical care as indicated. Because some of these patients have meet full criteria for Kawasaki or are very close to meeting criteria for Kawasaki, it's very important that they're recognized early and treated with the appropriate regimen to prevent the sequelae of Kawasaki disease, which can include coronary artery aneurysms. So they should be treated with intravenous immunoglobulin and aspirin if they meet criteria for Kawasaki. We have asked that providers call our provider access line at 866-692-3641 for any patient that they have who meets the following criteria. Less than 21 years old with persistent fever of, say, 4 or more days, and either incomplete Kawasaki disease, typical Kawasaki disease, plus or minus toxic shock-like syndrome, as well as having no alternative etiology that explains the clinical presentation. So we want to hear about these patients whether or not they have SARS-CoV-2 PCR test results, positive or negative. And that is it for me. Look forward to questions.
Thank you, Dr. Schillinger. We're just going to advance the slides now for Dr. Reichman.
Hi, good afternoon. Can you hear me? Okay, great. All right, as we move the slides up, so I'll introduce myself. I'm Jen Reichman. I'm the lab director for the New York City Public Health Lab. We can move on to the next slide. So I'm going to talk a little bit about testing. You just heard Dr. Schillinger refer to PCR-based testing as well as serology testing. So we're going to give a little bit of background about these tests and how and when they are and are not useful in COVID-19 disease. So, quote, PCR-based testing is where we detect viral nucleic acid through a nucleic acid amplification-based test. Most of these tests are reverse transcriptase PCR-based tests. There are a few other technologies out there as well. But these tests detect viral genetic material, so the RNA from the SARS-CoV-2 virus. These tests are best for diagnosing acute infection, informing clinical evaluation, and directing infection prevention and control practices. So if you have a patient in your practice or in the hospital, you have a positive viral nucleic acid amplification-based test, then you're going to change maybe how you handle that patient in terms of infection prevention and how you look at them clinically. These tests are performed on respiratory specimens, either upper respiratory specimens like nasopharyngeal or oropharyngeal swabs, nasal swabs, and new to this is saliva, or lower respiratory specimens like sputum or tracheal aspirate. So in contrast to detecting the viral nucleic acid itself, we can also detect the immune response to the virus. These would be antibody or serology tests. These tests detect antibodies to the SARS-CoV-2 virus, which generally become present 1 to 3 weeks after infection, and that is something that we are studying as well as the kinetics of antibody development in patients. These types of tests, when positive, present evidence of a previous infection. They are not useful for diagnostic purposes. They are, however, useful at a population level to do a serosurvey, and we'll talk a little bit more about that. They're useful for identifying patients who maybe have recovered from COVID illness and maybe candidate plasma donors for plasmapheresis for treatment for other patients. And generally, these tests are performed on blood, either serum or dried blood spots, although there's potential for antibody testing from oral fluids to come about in the future. We don't have those yet. Next slide, please. So a little bit more about MAT testing. So again, this is a test used to detect viral RNA. It's generally a reverse transcriptase, a PCR-based test. And they're generally real-time PCR-based tests. Again, there are a few other technologies out there like transcription-mediated amplification and others, but most of them are PCR-based. These tests are extremely sensitive. Some are more sensitive than others, and they're able to detect very small amounts of virus or viral fragments of the RNA in a patient specimen. What they cannot do is distinguish between viable virus or just viral RNA that's being shed or viral particles being shed by a patient. And what we have seen is that viral shedding can occur for days to weeks. It does not necessarily mean that the patient is still infectious at that point. They may just be shedding just RNA or dead viral particles. So again, a positive NAT does not necessarily mean the person's infectious. Days to weeks past the time that they are symptomatic. We just don't know at this time. The only way to be able to figure that out would be to do viral culture, which is something that cannot be done in a routine diagnostic lab. It needs a biosafety level 3 lab and specialized viral culture capabilities, which are just not generally available and have safety issues because of the infectivity of the virus. Next slide, please. So a little more on serology tests. These, again, are just intended to detect antibodies to the SARS-CoV-2 virus. There are different types of antibody tests that can detect different types of antibodies. So there's IgG, IgA, which is generally found more, it's a secretory antibody found more in saliva, IgM, which tends to come up earlier in infection, or some combination thereof. So when you order a serology test, you want to be mindful of what type of antibody or antibodies that test is detecting and what that might mean for your interpretation of the test. A positive result indicates the presence of antibodies that likely resulted from an infection with SARS-CoV-2. There needs to be a major word of caution here that there are some tests out there that may cross-react with antibody to related coronaviruses, including human coronaviruses that are widely circulating and cause things like the common cold. A negative result is interpreted as either no previous infection. However, there can be a, quote, false negative if the patient has not yet produced enough antibody to be detectable in the assay. So if the antibody test is done too soon, the person may not have produced detectable antibody yet, and the test will be negative. For people who are currently infected who are maybe symptomatic, a PCR-based or nucleic acid amplification-based test is indicated. If negative results may require repeat testing if the person had recent illness, again, to allow the body to produce enough antibody to be detected. Next slide, please. So one very important note about serology testing is that at this time, we do not know if antibodies or a positive serology test means that a person is, quote, immune. We do not know if antibodies provide protective immunity against reinfection. If there is immunity, we don't know how long that might last, if it's months or years or lifelong, as there is for some other viruses. So because of that, because we do not know, a positive test should not be used to make decisions about return to work or relaxation of other precautions such as PPE. So really at a single patient level, serology is not very useful because we are not recommending that any changes are made to that person's behavior based on the result of that test. Serology can be used to determine the prevalence of infection among the population, doing a so-called serosurvey, or again, identifying individual patients who might be candidates to donate plasma for their therapy for other patients. Down the road, once a vaccine is developed, we can use serology-based testing to verify vaccine response once we have some better information and better science behind understanding the immune response and protective immunity to this virus. Next slide, please. So we're going to talk a little bit now about FDA and emergency use authorization. So during a public health emergency, the FDA can use the emergency use authorization process to expedite review and grant temporary approval for diagnostic testing for that particular public health emergency. It's a means by which the FDA can review tests and provide authorization for their use as a diagnostic in a manner that is much more rapid than the normal 510K process that diagnostic tests usually go under. And this allows for diagnostics to become more readily and quickly available during a public health emergency. Clinical diagnostic testing also falls under the regulatory purview of CLIA, which is the Clinical Laboratory Improvement Amendment, and that is what determines the setting that a test can be performed in, whether it's in a high complexity laboratory or in a CLIA-waived doctor's office setting. So most of the nucleic acid amplification-based tests for SARS-CoV-2 that we see on the market now, many of them have received emergency use authorization for use as a diagnostic test, and most are designed to be performed in a laboratory setting. There are a very small number, it's 2 or 3, that have CLIA waived status. So those tests will have a W in the authorized setting column on the linked website. You can see the link below. These are CLIA waived tests that can be used in the point of care setting in a doctor's office, for example, or an urgent care center that has a certificate of waiver from CLIA. If the FDA grants an EUA for a test that is designed for use in the point of care setting, it may be classified as waived by CLIA. You need both in order for that test to be used in that situation, both an FDA emergency use authorization and the classification as a CLIA waived test. Next slide, please. So just recently, on this past Monday, the FDA made a policy change. So previously to that, for serology testing only, commercial manufacturers were allowed to basically inform the FDA that they existed, and then they were able to market and produce their tests and distribute them for use. Those tests were all classified as CLIA high complexity, and none of them were FDA authorized. So the new policy change now requires that all manufacturers of serology tests to submit an emergency use authorization request with validation data about that test within 10 business days of notification that the test exists, or within 10 days of the policy approval, or that manufacturer must remove the test from the market. So there's about 179 or 180 or so tests that have gone to the FDA and were listed on the FDA website under the old policy. Those were being marketed. Many of them were being marketed in the US, some not quite appropriately. However, all of those tests, if they want to remain on the market, need to submit an EUA and have their tests authorized by the FDA within 10 days. So they will have to submit by Monday, May 18th. So the FDA in this new policy also recommends specific thresholds for sensitivity and specificity. This is in response to some of those tests that were listed being tested in independent laboratories and showing that they had very poor performance. The FDA has also introduced a more streamlined process for EUA submission specifically for serology tests. So they have a document that test makers can use to, in a very streamlined manner, organize their data and present that to the FDA. At the bottom of the slide, we have a quote from the FDA stating, "The FDA will continue to take steps to appropriately balance assurances that an antibody test is accurate and reliable with timely access to such tests as the continually evolving circumstances and public health needs warrant." So initially, there was concern that serology tests needed to be widely available, and so the FDA sort of had a very open stance on allowing tests to be marketed. Now that we've got more data showing that these tests aren't all quite as sensitive and specific as we would like, and we're sort of moving on in our knowledge, and more tests are being developed. The FDA is kind of rolling that back and now requiring these tests to officially get emergency use authorization before they market them. Next slide, please. So a little bit about testing at the New York City Public Health Laboratory. So very recently, we have started accepting nasal swabs and saliva for testing using nucleic acid amplification-based tests for coronavirus testing. This is in addition to previously accepted specimens, including both upper and lower respiratory specimens. Any specimen collected on a swab needs to come collected on a synthetic fiber swab with a plastic shaft. Swabs that have calcium alginate, cotton, or wood have, those swabs can have elements that are inhibitory of the PCR-based test, and so they do not work, and we will not be able to accept those types of swabs for testing. Right now, PHL continues to offer testing for hospitalized patients with acute disease, and there is a process for obtaining approval by calling the provider access line and giving some information, and then we will authorize the test and will help with getting transport of the specimen to the public health laboratory for testing. Next slide, please. So as we move forward in the coming months, as we move into the suppression phase of the outbreak in New York City and begin to relax mitigation policies, we will need to do that in conjunction with making sure that extensive viral nucleic acid amplification testing is available, and as that will be critical to finding people who have acute disease with COVID-19, whether they're symptomatic or asymptomatic. That testing will be coupled with contact tracing, and that will be used to curb the spread of COVID-19, as was discussed in our seminar last week. Serology testing will be used in conjunction with serosurveys, and there are a number of serosurveys happening right now and are planned in the near future in New York City. This will help determine how widespread COVID-19 was within New York City, and also help to provide insight into the immune response to the virus, which will help us better understand things like whether infection produces immunity in patients. We don't know that yet, but we need to do these serosurveys as well as time course serology on single patients to understand how that works. Next slide, please. And on this last slide here, we have a number of different resources for coronavirus. I believe that's our last slide, and we're very close to the top of the hour, so I will hand it back to the team over at Gotham to see if we're able to do any quick questions. Thank you.
Thank you, Dr. Rickman, and to Dr. Ray and Dr. Schillinger for all the important information you've shared. We have a few minutes remaining for Q&A. As a reminder, you can submit your questions via the Q&A section of the WebEx text, the chat box. And we have been joined by Dr. Mary Foote, Healthcare Systems Planning Lead for Outbreak Response, who has been valiantly answering most of your questions there. So please go ahead and look there for more information. One question for Dr. Rickman. Can you speak on the FDA EUA approved tests, and does that process ensure specificity for SARS-CoV-2 and no cross reaction?
So it sounds like the question is about serology testing. And so the emergency use authorization process requires that test makers provide a prescribed set of data to the FDA for review by the FDA. So some of that data that the FDA requires includes things like specificity data, as well as sensitivity data, some analytical data, precision and accuracy, things like that. So tests that have been given an emergency use authorization that does give a level of those tests have undergone a level of scrutiny by the FDA. Any laboratory that's going to put that test online needs to do an internal validation to show that the test works well in their laboratory as well. And so when we do that in my lab, for example, we run some assessments to determine specificity and sensitivity in our lab as well. So any test that goes online in my lab, we don't put it online unless we are confident in those results.
Thank you. And also another question for you. Are home specimen collection kits for PCR tests available and approved in New York City?
So there are not. There are 2 home collection kits that have an FDA emergency use authorization at the national level, but there are none that are available within New York State because those tests, although they have an FDA emergency use authorization, are not approved for use within New York State. So there are currently no home collection test kits available in New York.
Thank you very much. And we'll do one last question to all our panelists. Can you discuss the 2 types of COVID? Is there an East Coast and a West Coast strain?
So this is Jen Rakeman. I can speak just a little bit about that from a laboratory perspective. So nationally, in many laboratories, we are doing sequencing of the from viral specimens from patients across the country. And there's some very interesting data and some very interesting data where you can look at all of the published sequences at once in a phylogenetic tree and also on a map. And there's a website called NextStrain that's publicly available where you can look at that data. And it does sort of link sequences to the geography where that patient was, where that specimen came from, and then how that links back on from a phylogenetic perspective to viruses that have been isolated elsewhere around the country and around the world.
And this is Dr. Ray. I think that also in terms of the clinical picture around the viruses, there are a lot of, binary kind of like 2 kinds of COVID conversations. And I don't want to confuse the different virus conversation or the different, genetic conversations with the idea that it seems that there are 2 kinds of what we call phenotypes of the clinical picture, which, where some people get very sick, have the clotting we talked about today, they're on a ventilator, and some people appear to be doing fine but have low oxygenation. And so you may have heard them called the H and L phenotype, and those do not appear to be, whether a patient experiences one phenotype or the other, doesn't seem to be related to the actual genotype of the virus.
Thank you to all our panelists for your presentations today and for answering those few questions. That is it for our time for questions. So please do refer back to that Q&A box if you're looking for answers on more of those questions that Dr. Foote was able to get to. As a reminder, we do post PDFs of our slides as well as recordings of all our previous webinars on our provider webpage. You can find that information on the screen right now, and we will also send follow-up for our next webinar early next week. Thank you for joining us.